good evening, everyone, and welcome to this opportunity for us to have a candid conversation with COVID with those of us who are first line workers in the community, as well as those of you who are on the medical side of it. I am Victor M. Davis, the pastor of Trinity Baptist Church here in Columbus, Ohio, and it's great to have everyone with us. Reverend Janet Shepherd will be assisting me in this discussion, and we are thankful to all of you who are joining in and calling in and posting questions. And we'll start off introducing ourselves with Lauren Sutherland.
Oh, you had to pick me first.
Yeah.
I'm Lauren Sutherland. I'm an emergency medicine doctor at Ohio State. I've been here for about 8 years now. And I also run our clinical research, which has been, used to do a lot of everything, but this past year we've done a lot of COVID research. So hopefully I can answer any questions around that.
Yeah, we'll come back to that clinical research, especially as to how it affects African Americans and the need for Black and brown populations to be a part of that. I don't want to mispronounce names. Fahad, did I say it right?
Yeah, perfect.
Very good.
I'm Farhad Aziz. I'm one of the ER physicians as well. Work primarily at Maine, but do a few shifts at OSU East as well. I take a particular interest in medical education, but also social emergency medicine and how it pertains to health disparities and health inequities.
All right, Mercy.
Hi, I'm Mercy Dixon. I'm one of the senior residents at OSU and also one of the co-chairs of the Diversity, Equity, and Inclusion Committee for the Emergency Department, along with two other amazing people, Dr. Cooper and Dr. Desta. And I'm super excited to be part of this, so thanks for having me.
Keithia.
I'm Jakeithia Butch. I kind of do a dual because I'm a member of Trinity Baptist Church, and I also work at OSU ECD.
All right, Rob. All of these other folk people are doctors. I'm just going by the first name because I don't want to mess it up.
And that is fine. I'm Rob Cooper. I'm a emergency physician at. We're working on this. Actually, Jakeithia and I are at the Columbus Free Clinic tonight.
Okay.
So I think they're trying to broadcast from the same place.
Oh, oh, I see now. All right, Reverend Jan.
I'm Reverend Janet Shepherd, pastoral assistant at Trinity Baptist Church, as well as I'm a registered nurse with over 35 years of experience at, my whole career was at the Ohio State University Wexner Medical Center, and now I'm doing some adjunct faculty teaching in College of Nursing.
Rasheen.
Hey everyone, my name is Rushan.
I'm sorry.
No worries. Not all the time. My name is Rushan. I am also one of the senior residents and one of the co-chair residents for the Diversity, Equity, and Inclusion co-chair as well with Dr. Dixon and Dr. Cooper there. It is an honor to be part of all this. Thank you so much for having us. Thank you.
And Kelly.
Hi everyone, I'm Kelly. I'm also one of the current senior residents at OSU and one of the residents also on the DEI committee. I am also currently working at East, so I'll be sort of in and out, but honored to be a part of this discussion this evening.
Oh, wonderful. Again, we welcome all of you and your professional expertise, and congratulations to all of the residents that we have.
Yeah.
And we're glad to have you on the front lines and touching our communities firsthand. I have officially become a fan of the Ohio State University, OH. Especially when it comes to my health care. So
yes.
When it comes to my health care. So let's get started. Let's get started. Jakeithia or Reverend Jan, let's talk a little bit.
All right. I know a big question that I hear from a lot of people who should get the vaccine and who shouldn't get the vaccine. So can you share a little bit of information about that?
Okay, residents, don't y'all jump in at once.
Go for it.
All
Yeah,
right.
I think when you're talking about getting the vaccine and who shouldn't get the vaccine, I think it's first pretty important to understand like how vaccines work. And typically what ends up happening is the shot that they get or that people get, and we've gotten them throughout our childhood, whether it's chickenpox, whether it's polio or hepatitis vaccines, they're all meant to build our immunity. And what they do is they introduce a particle of the virus, and the cells recognize that and they create what we call antibodies. And then the theory is that when, or not necessarily the theory, but what happens is that if you do get infected, then you are able to fight it off the next time you're exposed to that particular virus or that particular protein. So from our standpoint, anybody who doesn't have any history of allergies or what we call anaphylaxis to the virus should, or to the vaccine or mRNA vaccines, should get it. I think there's other ways that you can kind of look into who hasn't been studied yet, and children should probably not get it at this point just because the research hasn't been done on kids, but that's kind of where we are with that. So anybody above the age of, I think 16 or 18, I believe is the cutoff.
I believe it's 16 years old and older with Pfizer, and then with the Moderna vaccine, it's going to be 18 years or older.
Well, I was wondering, so who shouldn't get the vaccine?
That's a great question.
Yeah.
So I think based on what we know, pretty much most of what Dr. Aziz has already said. So they've studied age, they've studied ethnicity and race, they've studied sex, and a number of other categories. Right now, the biggest class of people who should not be getting the vaccines are people who have developed anaphylaxis or any potentially life-threatening kind of reaction to specifically mRNA vaccines in the past and even other vaccines in the past. So that's a conversation you want to be having with your doctor and seeing if you've had these kinds of reactions before. I understand there's a lot of misinformation on who should not and who should be getting the vaccine. So it's really important that when you're asking these questions and you're figuring out whether or not you should be getting these vaccines based on reactions you should have in the past, not all reactions to drugs or vaccines are the same. So it's really important that you're having these conversations with your physician. So those are the people who should not be getting the vaccine. They did not study the vaccines on pregnant women, and there are a lot of people saying you should not be getting the vaccine if you're pregnant, and that's not entirely true. We know that there are not a lot of data that show that pregnant women get severe reactions from the vaccine. And I'm happy to forward information from a physician colleague who got the vaccine while she was pregnant and has really good information about that. But I do recommend that if you're pregnant, that you're having these discussions in the same way with your obstetrician and kind of deciding whether you should be getting the vaccine or not. But so far, we know that pregnant women are more likely to have severe reactions compared to the rest of the population, but their risk is also low. So the big thing to take away from this is make sure you're really discussing it with a physician and with people who have significant knowledge about the vaccine.
One thing the doctor said, it was that, or he inferred that a lot of the vaccines in the past, there's a part of the actual disease that is in the vaccine. At least that's the understanding that is out in our community. Clear that up for us about the COVID vaccine. When we get the shot, which I have gotten, I'll get my second one on tomorrow. I'm getting the Pfizer one, by the way. No, I'm not being paid for that advertisement. I should be. But you do need to buy some stock in Pfizer if you don't have it. So explain to us what this vaccine is made up of? I understand it's proteins and sugars and that kind of thing. Talk to us someone about what the vaccine is made up of.
Rob, did you want to show the pictures you had?
Yes. So we're doing a little single and double computer action here, but I do have it up on mine. So they're not made of the actual virus. What they're made of is something called mRNA, which is going
say that a little more clear and distinct for us.
Pastor, I will try. Speaking voice here. They are not made of actual virus particles as some of the other vaccines in the past are. They're actually made of mRNA, and what that does is that actually gets your body to help produce antibodies against part of the virus, and it produces antibodies against something called the spike protein, and that is the protein that actually spikes your cell and gets that virus into your cell. And so this shot doesn't actually have any virus in it at all. All it does is it kind of gives your body the code to help make the immune cells that are then going to go and kill that virus. So in some ways, it's even safer than getting dead virus. So when you get like a polio or measles vaccine, you get kind of dead virus injected into your body. This is actually just a single protein, and all that does is get it so your body can recognize COVID and go after it. So it's really cool technology and really safe technology.
That's neat. I think that's very helpful to understand. Is this the first time that type of technology has been used for vaccines? Because I know a lot of people also think this is a test and it really hasn't, they're doing something different that they haven't done before. So can you explain, has that same technology, that same science been used in other vaccines? Or is this the very first time with the COVID vaccine?
It's about 10 years old. So it's not a new technology. And one of the ways we were able to get, and I say we as sort of everybody in the world was able to get vaccines together because your tax dollars paid for making and buying these vaccines, is that these companies took strategies that were already in place for other vaccines. There's constantly research in this area, and then they just took first we figured out what virus is it, what's its genetic code, how does it get into the cells, and once they isolated that protein, then they could get the mRNA to make the protein and make it go.
We've got a question, and I don't want to mispronounce their name, but the question is, should we be concerned about the new COVID strands? And the second part of that question is, can we travel once we get the vaccine? Let's take part A first. Should we be concerned about the new COVID strands?
I could take that one. Yeah, I mean, I think that you should be concerned about it probably equally, if not a little bit more than we were with COVID to begin with, mainly from the transmission standpoint. So what we found with the new variant is that it's easily transmissible. So they're saying that, maybe we should be wearing 2 masks instead of 1. Staying indoors is still the recommendation. Staying 6 feet apart, always having your mask on, no significant social gatherings. So it hasn't really changed from that perspective. I mean, yes, there's a higher risk that you may get it once. I think that they just found it in South Carolina, if I'm not mistaken. But once it starts coming into Ohio, then yes, it's going to be more of a concern. But in answer to the second part of the question, sorry, let me rephrase that. I think the question was, does the vaccine prevent the variant? And I think the answer to that is still yes. The variant is more transmissible, but it still has the mRNA vaccine will still vaccinate against that vaccine or that virus. And answer your second question, I think that until our numbers come down to a certain level across the country, it's probably still not entirely safe to travel. I mean, if you have to do it, you have to do it for whatever reason. I think some of us still are doing it if you have to do it for work. But trying to avoid it as much as possible, unnecessary travel, is probably the most beneficial.
So it is your recommendation that we continue to wear masks and PPE and social distance even once we've had the vaccine?
Yes. Yeah.
Oh, shoot. I'm sorry.
Yeah.
but I'm not the only one that feels that way.
No, absolutely. I mean, and I think that's one of the misconceptions, you know, is like it's the same thing as when you have the flu and things like that. When we get vaccinated, when we see patients in the emergency department, we still wear our masks. They're still under droplet precautions and things like that. So we still take the care, because it's not necessarily whether we get infected or whether we get sick. It's who do we bring it home to? You know, are we bringing it home to unvaccinated people? Are we bringing it home to people who are at risk? That's also the biggest concern.
Talk to us a little bit about, I know with research, and it is my understanding that that COVID has been around for a while, from what I understand. You all correct me if I'm not correct. And is that a yes?
Coronaviruses, this class of virus has been around for a while.
Okay.
Yeah.
The coronavirus has been around for a while. So the work to find a vaccine did not necessarily happen overnight. This is something that has been going on. It was expedited, but it's been worked on for years. Am I correct?
Yeah. Go ahead, Cal.
Yeah, no, I was actually going to add on to when Dr. Sutherland was discussing the mRNA technology. In addition to this not being the first mRNA vaccine, as you mentioned, coronavirus, COVID-19 is a type of coronavirus, in which these have been studied from years before. So although everything was sort of dropped to develop this vaccine in particular, foundation was already laid prior to us needing to develop this vaccine, which only expedited things and aided in it being developed in a timely fashion.
Yes, Jean Frey, I'm sure you all know who that is. Dr. Linda Sayaf is one of the country's leading researchers in the COVID-19, that's what I'm gonna say, in the COVID virus. So we wanted to make sure that we know we have people who are connected to experts in the field. Talk to us about the need for persons of African descent, African Americans and Indians, as well as Hispanics, to be involved in testing.
Ooh, that one seems for me.
Yeah.
So I think you have to think about research as how we discover anything in the world. And right now, whether you like it or not, we're all kind of participating in research. Every time you answer a survey about a product you use or rate something on Amazon, you are giving data back to people, and that's research. And a lot of research is simple like that, or, you know, I tried to teach 10 dogs how to obey and only worked in one, so this technique doesn't work. But when you're doing more complicated research, like how does this molecule or drug affect somebody, people are so different. And no matter how much we look at animals, you can't predict people. You know, even if I give 1,000 people a Tylenol, you're going to get a different reaction. Some people are going to be allergic. Some people have great pain relief. Some people will say Tylenol is like eating Tic Tacs. And so you have to have enough people and enough different people to average things out. And then you can take that big group and say, all right, on average it worked, but maybe it works really well for women, but it doesn't work well for men. Or something else. Maybe if you have this gene in your ancestry, it works really well, but not for someone else. So then you take the big group, does it work in general? And then you break it down into subgroups, who does it work the best for? And that's why when you're doing such an important study, like a virus that affects the whole world, you want to make sure that you have people of all kinds, shapes, colors, diseases, you know, is it work as well as someone with asthma, someone who doesn't have asthma, so that you can do these big things?
So I'm actually in 2 trials. I just got done with the HERO trial from OSU with Dr. Sutherland. And also I'm in the Johnson & Johnson's vaccination trial. I've been vaccinated since November the 1st through their trial. So I did not get 2 shots. I got 1 shot only because of that.
Tell us what the HERO trial is.
So the HERO trial was through Dr. Sutherland, and it was for first responders to see how we reacted to, Dr. Sutherland, help me out. What was the medicine?
You're just getting shots and don't know what you're getting, Jakeithia.
No, remember at the start of this, way back in March, and there was some data out of China that hydroxychloroquine, which is an
Yes.
anti-inflammatory used for rheumatoid arthritis and lupus, there was some data that people who were on that didn't get as sick. And so the US government actually funded a study saying, let's see if we give this drug, not just after you get sick, if we give it before, if it can prevent people from getting COVID. And we don't have the full results yet, but they had several thousand people randomized to either get hydroxychloroquine or a sugar pill, a placebo, and then they'll see whether it worked or not. But Chiquita was nice enough to be involved in that study.
Okay.
So can I ask a question that I know people have, and that being that, so more people of color should actually participate in some of the clinical trials, because as you mentioned, a Tylenol can react a different way in different people based on body makeup and that kind of thing. So the more diverse of people that participate in the trials, the better data can be gathered so that we can have more information as to what will be effective against what and what's not as effective against things, like helping with some of the, I guess, health disparities somewhat.
Mm-hmm.
Yeah.
And I think, Reverend Jan, along with what you're saying, is the lack of information that is put out in the communities that we speak about. One of the greatest avenues to get information out is through the African American church.
Mm-hmm.
That is the largest audience you have of gathered African Americans. I shouldn't just say churches, but religious organizations, because you have a large group of African Americans there. And if you work through the leadership, such as myself and Reverend Jan and other pastors, there's a level of trust that they have when they hear it from us. And people are more prone to trust the system when they hear it and hear it as affirmed from us. For example, some of the myths that I need you to help dispel tonight is that they're not putting a chip in us, that we're not being traced. There's some type of chip being put in us. Do you all have chips put in you all?
No, and the needle's really small, so it'd have to be like, I don't know.
Yeah.
I've never seen a chip
Yeah,
that small.
but that is a myth. That is a belief that is out there, that this is from the church's perspective. This is the mark of the beast. This is the sign of the ends of time. And I'm not one to get into that. The Lord handles his business and we ought to handle our business. And when he says we will do even greater things, these things such as the vaccine and your knowledge in the medicine field and science are greater things, in my opinion. Not only that, I tell people, you talk about being traced. You carry a credit card and a cell phone. They know where you are at all times, and you've got GPS on your car, so you being followed. You got a social security number. So those are some of the other things. Reverend Jan, what are some other questions we might have?
I was going to also mention about like that we're not being used as test dummies or that type of thing.
Mm-hmm.
I know that thought process is out there. Can you talk a little bit about, and that goes all the way back from the war, from Tuskegee Airmen, that kind of thing. Can you talk a little bit about how things are regulated?
Sure, and I think
about even with your studies, how the government, the process it has to go through to be on the up and up, so to speak.
I would love to, and I'd also like to address something that Pastor Davis brought up, in that the importance of having all sorts of people from all sorts of walks of life being in trials. In cardiology, all the big trials back in the 50s, 60s, 70s were on white men. And it just so turns out that men tend to come in and say, I have crushing chest pain, it's an elephant sitting right here and it goes down my right arm. So all the text was written that that's a heart attack. And then we find out that women tend to say, I'm having a little discomfort, but I'm fine. I'm going to go do 6 loads of laundry and then take care of things and then come in maybe tomorrow. And they had this just as severe a headache, heart attack. And so if we don't involve everybody in trials, we're going to get data that doesn't apply to everybody, and we're going to miss big things like heart attacks in people. So
the other thing I think is that trials, it's the best way to have a follow-up. I mean, because I'm in this trial, I get my blood drawn every 2 weeks to see of my antibodies. So, you don't get that without, and that research, respect and that questions. I have people that are following me if I have any questions or any concerns. You don't get that unless you're in a trial. And there are some trials for, like, if you have, diabetes and you can't afford your meds, there might be a trial that can help you that has more, medicine that's available to you. Or, the thought of joining a trial to be able to be on the ground floor of it, to know that I've contributed, was big for me. So there are so many trials that are available that I think people miss out on that could benefit you, that would be no cost to you, and you could get more meds or more, doctor's assistance that you would never have access to.
But I completely understand the fear, because in the past, research was really bad.
Yes.
I mean, the first vaccine, the first smallpox vaccine, Edward Jenner said, oh, look, milkmaids get cowpox, which is a milder form of the virus, and then they don't get smallpox and die. So he grabbed a milkmaid with cowpox, grabbed his gardener's son as like, oh, here's a child on my land. I'll just take this child and infect him with cowpox, and then exposed him to smallpox repeatedly and said, look, the child survived. I've invented vaccination. And that went on for hundreds of years. People would felt that.
Not only that, but within the African American community, when you think about the Tuskegee experiment, which was endorsed by the government. So, there's already when you look at someone of my color, there's already a apprehension to offer ourselves to be a part of any kind of study because of what has historically been done. And I'm losing the name of the lady that had ovarian cancer, and her cells are continuously being used in cancer research within our culture without
Henrietta
her.
Lacks.
Yep, Henrietta Lacks.
Thank you. Say it again for me, please.
Henrietta Lacks.
Henrietta Lacks. I had the first name. I couldn't think of the last name. And how many more persons in earlier days that has been done. So we have to educate our community of the systems that are put in place to prevent those kinds of things occurring again. And the best way to do that is for them to see more people such as Dr. Robinson, Dr. Dixon, Dr. Tesfaye, Isaiah, see more of them on the forefront and giving information that everything is going to be okay. I was apprehensive about getting the shot. I was very apprehensive about getting the shot. But when I considered my job as a pastor and a chaplain around a diverse populace of people from my children, I figured I got the flu shot and I lived. I got other shots and I lived. And I'm one of those persons, if I'm sick, I'm going to the hospital and they put an IV in me, I'm taking it. So I got the shot. And at this moment, there's nothing growing out of me. My mental state was already shaken before that. So, but I'm going to get the shot tomorrow. Now, I will say that I did take some precaution. I read some articles that say, take a couple of Tylenols and that kind of thing. So I did not have any reactions to the first shot. I've also heard that the second shot you have some reactions to. I'm going to do the same thing. I'm going to take some Tylenol and we'll see tomorrow. But I would encourage everyone who is listening or that will listen to this webinar, when you have the opportunity to get the shot not only for your well-being, but for the well-being of others. It is so important. And And oftentimes my doctor, who is a physician at the Ohio State University, Dr. James Lawler, he tells me, quit reading Google, let me be your doctor. And I'm sure all of you would agree by the smiles and the nods I see on your face. Don't let Google be your doctor. And so what else do we want to talk about tonight?
Someone sent me a question, and you're right, Pastor. Dr. Google really doesn't win a lot of cases. Yeah. So
I do like when people come in with questions.
Yeah, I will say one thing just to kind of go back to the research thing. I don't know if it was explicitly said, we kind of beat around a little bit, but I think that compared to the history of research in America, especially in minorities and Black Americans, the history is not good. But right now, and I think Dr. Sutherland can attest to this, the need for good ethics when we do research or when we come up with a project is almost the #1 thing that we have to consider when we're doing research now. The number of hoops that we have to jump through in order to make sure that the thing that we're studying is ethical is good. I mean, it's good, but it is also a ridiculous amount of hoops that we have to jump through. So Dr. Sutherland does most of the research in our department, so I'll kind of let her know, or let her talk about that.
As soon as you have a research idea and you come up with a plan, you have to make sure that it is ethical, that it offers some benefit either to the participants or to humanity in general, and that it has a purpose. So that's called beneficence, that it is equitable, and that you're giving this opportunity to everybody who should deserve it. So if I say I'm going to do an amazing trial about giving a new diabetes medication for people with really bad diabetes, but I'm only going to give it to people on this side of town, in the rich side of town, then our institutional review board, which reviews, it's a group of scientists, lay people, so just regular people, a big group, they'll read it, review it, and they'll say, no, this isn't right. You can't do it like this. And then there's oversight for everything. So you have to report back. You can be audited at any time by your institution, by the government. And any study that has any risk to participants will also have a data safety board. And that's a group of people that aren't even in the study or associated with the study. So it could be people from different universities, and it always has to have, again, people from the community on it, not just scientists. So when you hear things like the Oxford vaccine trial is being held for a moment for the data safety review board because a participant had a bad reaction, that's them saying, hold it, we want to review continuously, and anytime there's any bad outcome, they'll stop and take a look at all the data and say, okay, that was just random chance. If you have 20,000 people, somebody can get appendicitis, or somebody could die of a heart attack, or this is 3, 4, 5 people with heart attacks, we're stopping the trial. So we want to have lots of different layers of people breathing down your neck to make sure that any researcher is doing everything they can to protect people involved in their research and make sure it is high quality and good.
Hey, Dr. Aziz, thank you for having Dr. Sutherland flush that out a little bit more to help increase our comfort level with the research. Yeah. So thank you so much. Now, I do have a question that someone texted me. They said, thanks for being on. They said, if early on we mentioned checking with your PCP to find out if the vaccine is right for you. And it says, if you don't have a PCP to get advice from, who can folks talk to get that advice? Should I take the vaccine? Should I not take the vaccine? Who can they talk to? Is the Ohio Department of Health an opportunity? And I realize that's not what you all aren't from there, but what might a person do who doesn't have a PCP to find out if the vaccine is right for them and their health condition?
I think I'll take this platform to initially say that everybody, if you don't have a PCP, should go out and get one. I think it's absolutely important to have somebody who is chronically looking over your labs and looking over your health, rather than coming to the emergency department, which we are always happy to take care of you, but we see one snapshot, whereas somebody else can see the whole picture. So that's my first thing. As far as who you can ask questions to, it depends, I guess, on what questions you have. I'm not sure if OSU has a system set up to where we can ask questions about the vaccine. If you do find yourself in the emergency departments, we'll always ask questions, but there is a phone number, I think 1-833-4-ASK-ODH is in the chat.
And some of the common questions that I've been asked are, can I get the vaccine if I have an egg allergy? There's no egg in the vaccine. There's no latex in the vaccine.
Yeah. There is, if you have questions, the Ohio Department of Health, 1-833-4-ASK-ODH, and they have a staff person available from 8 a.m. to 9 p.m. daily. Also, just a little bit of information, and to reiterate, I think we're pushing, all of us are endorsing more persons of color being a part of research. And if you are interested, I would suggest you go to the website studysearch.osu.mc.edu. Again, that's studysearch.osu.mc.edu. A little bit more information, 20% of those that were tested, 20% of those who were in the vaccine trial for Moderna were non-Caucasian, as well as 18% in Pfizer. And
Pastor?
Yes?
I was just going to say, also, it sounds like currently African Americans are 4 times as likely to be hospitalized with COVID,
Yes.
and nearly 3 times more likely to die compared to Caucasian victims of COVID. So,
and as a pastor who is also a chaplain, Trinity did its first funeral for someone who died of COVID. And then we've had several disciples in the church who have been COVID positive, some that some that were asymptomatic, some that were had all of the symptoms. And of course, me being a chaplain in a extended care community, I've seen it from the beginning to the end several times. And so, you know, tomorrow the residents will be lining up for that vaccine.
I just want to take this moment to just address a few things that have come up. One of which is I agree with Dr. Aziz about making sure that you get a primary care doctor. That is really important. And I, in that same breath, want to acknowledge that not everyone has easy access to a primary care doctor. And if that's the case, there are free clinics across Columbus. And hopefully we can add some of that information to the chat. But in this case, Google might be your friend. And there are ways to look up where you can get access to free clinics. I know Dr. Cooper works with the perfect. Jakeithia just posted it. I love it. Quick. So I think that it's a really important thing to have a healthcare professional that you can go to with your questions. And a primary care doctor is one way in which you can do that. And if you can't do that through your insurance, you can do that.
I'm on this webinar, but I will do that.
The other thing that is really important for us to understand is that it is okay to be skeptical. I think that it shows that you're thinking, and we should be doing that more as a group of people, and we certainly should be doing that as minorities in a system that has not really favored us over the last decades, centuries. We are doing better. We are making strides to be better as a country and as a healthcare system. There is still room for development. And I think that as we push on our country, on our healthcare systems to be more accountable for the disparities within our minority communities, we as a group also need to take responsibility for how we can own our health and our lives. And part of that is doing the research, but part of that is also taking advantage of opportunities that are available to us as we scrutinize the data, like we're doing right now, having conversations about it, going to your PCP, looking up the data that are available online through reliable sources. Instagram post from an influencer is not necessarily the best thing. And I know that we have a tendency, myself sometimes, to be persuaded by people who are being followed by a million people, but these people aren't necessarily always experts in these fields. So I think the same thought process we use to scrutinize the data that's coming from the research, we should be using to scrutinize people on Instagram and other social networks that are providing us with information that can be life-threatening. And I say life-threatening because it can be. Your granddaddy, your grandmom with diabetes, hypertension, once gets COVID, can be in the ICU. I've seen this personally. So I think that as we're being scrutinized on one end, we should use that same efforts on the other end. My dad is a clergy. I grew up in church. I went to a HBCU, Prairie View NM. I have learned about the disparities in our country, the history, the very deadly and dark history towards African Americans in this country. So I understand where the skepticism comes from. I was initially skeptical. I try to keep a skeptical mind of all things because I think it keeps us on our toes. But I think it's important not to let skepticism get in the way of good decision making. So I just really want to encourage people to understand. I understand that I'm with Pastor Davis on this. I'm all for faith. I am all for prayers, and I am all for the power of miracles and belief. At the same time, I also believe in good data, and I believe in that one is not mutually exclusive of the other, and that we should be making decisions that work for us in our community. There are too many intelligent people, too many people that are useful for our families, too many people that are useful for our economies that are dying. 3 times the rate of Black people dying compared to Caucasians is way too much. And by choosing not to protect ourselves, we are leaving ourselves open to formulating some of those disparities that have gone on outside of us, and now we're adding to that system. Mm-hmm. So I just want to take this time to say, I hear you, and I think it's okay to be skeptical. Just make sure you're making the decision that works for you and your family.
I tell people all the time, I preached a sermon a few years ago, you need scripture and prescription.
That's right.
You need scripture and prescription.
That's
and not to offend anybody, you need Jesus and a doctor. So, let me give a little bit more information, Reverend Jan, that's come up for us. If you do not have insurance and feel like you cannot afford a physician, I encourage you to go to columbusfreeclinic.com. You can also, if you don't have access to technology like many do, I encourage you to call the health department or your local faith organization for directions and assistance. I guarantee that there's somebody in your faith organization that's in the health field and that can direct you to the proper channels and can even assist you in getting the assistance you need. The free clinic, I need a little bit more information on the free clinic.
Location maybe?
Actually is right here to tell you everything that you need to know about the free clinic.
Awesome.
Oh, okay.
See, we're at Jakeefi and I are tonight, volunteering, taking a little break right now, but we are open every Thursday night near the corner of Lane and High at Raritan Family Practice. We do primary care, we do urgent care, staffed mostly by OSU doctors and students. And we see almost 2,000 people a year, so we'll make room for you. We got free medicine, free labs, and free x-rays.
Is that the only free clinic that OSU provides in the city?
That OSU provides.
No, so we're Thursday nights. There's a free clinic that Dr. Aziz volunteers with, and I'll let him speak about that on a different night.
Yeah, actually on Wednesday nights we do the Noor Free Clinic, NOOR, and that one we see probably about 10 to 15 patients a night in clinic, and then as well as virtual clinic as well. Most of the virtual clinics are medication refills, things like that. We have access to the Columbus Charitable Pharmacies, and then we can also refer people to specialty services and imaging and labs, whatever they need, and then we see them back in clinic and update them over the phone as needed. So those are the 2 clinics that I know of.
And where is that located?
That's actually, it's on Wednesday, right? I think right where Dr. Cooper is right now. So same place, Raritan.
Okay.
Same floor, 2nd floor, Raritan.
Okay.
We have a question. For a person that has never had the flu shot, should they be concerned about some type of response in getting the COVID shot or the vaccine?
Go,
Yes.
Kelly. I can see you want to talk.
Yeah, I was looking for the unmute button. But yes, with getting any vaccination, one is susceptible to developing what we call sort of just symptoms that's similar to having the vaccine itself, whether it's body aches, developing a fever, a cough, and all that's just sort of as your body processes this new material that it's taken in, and it's to be expected. Sort of as we've been saying earlier, and being a sort of public figure and all of us getting the vaccines, I think it's the importance also about being transparent about what we're experiencing as we're getting that first dose and that second dose. I myself got the Pfizer, and I only had arm soreness with each dose itself, but I've had friends and colleagues who had fevers for a couple of days after getting the vaccine as well. So it's a spectrum, it's a range, but I think being upfront about what we're experiencing will help sort of dissipate any concerns about getting the vaccine itself.
Mm.
Yeah, the fever is actually your body's immune system trying to fight something off. You've probably heard people say it's your body trying to burn the virus up. Well, it's because your body senses something's out there and it says, we got to change something to get rid of it. So this is just, it's all inflammation, which is what the vaccine's trying to do. It's trying to build your inflammatory response. So I had the night after some fevers and chills and muscle aches, but it only lasts a day. And then I felt like, haha, it really worked for me. It triggered my immune system.
But the other part of this is the lack of knowledge the general populace has on how the body works. And so much information, I remember, when I was a child, if you got a cold or something, and it probably was the flu or pneumonia, grandma rubbed you down in some type of slab, mentholatum or Vicks, wrapped you up and told you gave you some literally alcohol, put you to bed, called it a hot toddy, and you sweated it out. Well, tonight you've let us know that fever and sweating it out is actually the body's way of fighting it off. And I deduced that by critical thinking. I think if we would provide more opportunities on how the body works and responds to things, that people be a little bit more comfortable, understanding white cells and red blood cells and copper tunnels, and it would just help us out a whole lot more.
Yeah, even just the soreness in your arm after a vaccine, whether it be your tetanus shot or your flu shot or anything, that's all those immune cells rushing to that area to say there's something different here.
Yes.
So it's the same kind of soreness you get if you have inflammation in your muscles from working out or something else. So
thank you for offending me.
May I ask a question that I know people have? So one thing I wanted to mention that was also mentioned earlier, if I don't have the PCP and that kind of thing, it was mentioned that you can ask where you are getting the vaccine if it's right for you. There should be someone there that can help advise you as to should you or should you not. So that's one thing I wanted to add. And then some people are confused about herd immunity. So can you explain a little bit about that? They're saying, well, I'm not going to get the vaccine because I'm waiting for herd immunity, which help us understand why it's better for us to be vaccinated versus waiting for the herd immunity.
I think that's Dr. Cooper's jam.
That is absolutely. So I work with a lot of big populations on thinking about how we vaccinate and how we don't. So for a virus to jump from person to person, it's got to go from an infected person to an uninfected person. It can't go from a person who's been infected to a vaccinated person because that person already has immunity. And so the virus, you see these things where somebody goes, gets it and goes home, then all their family members get it because the virus can jump around. But if everybody around that person at home is vaccinated, that virus has no place to go. And once it no longer can infect the person who has it, it just dies. So we know that when you're out in the community, if 8 out of 10 people you're around are vaccinated, you're not gonna be able to get, the virus isn't gonna be able to keep growing because it's not gonna have the place to grow. But I think the scary thing, and the thing why we have to get the vaccine, is we need 8 out of 10 people, 80% of people in the US, maybe even 90%, to either have gotten the virus or to have been vaccinated. And right now, the estimates are worth about 8 to 10% of the population has had COVID or has had a vaccine. So we're 80% away from where we need to be. And in a country of 360 million people, we need 200 million more people to get the virus or to get vaccinated before we're herd immunity. So if you're waiting for that, you're going to be waiting through the summer, you're going to be waiting in the fall, and you're not going to be traveling, and you're not going to feel safe at night. So the first thing is, waiting for it, that's a long wait. It's going to be a long, long wait. And the second thing is, if you want to be part of the solution, get the vaccine and start adding to that percentage.
Thank you for helping us understand that, sir.
Here's a
And I think there's one thing that we should probably clarify. I know there's a lot of fear about the vaccine because of the potential risk of getting it. I think that's why we're having this conversation. I think it's important to understand that there's risk with everything that we do, right? There's risk with getting into the car and driving to work or going to the grocery store. There's risk with eating meat. I mean, we've all seen the E. coli from lettuce and being having reactions to bad food. So anytime that we do something, we have an inherent risk to it. And I think that now what we have to do is we have to weigh the risk of a potentially bad reaction to a vaccine versus actually getting COVID-19. And I think that we've all heard the stories. The physicians here have seen the patients suffer in the ICU and suffer in our emergency departments, gasping for air, and it's troubling to watch, and there is a very high likelihood that if you have a certain number of comorbidities, and when we say comorbidities, we mean like diabetes and hypertension, things that put you at risk, that you could potentially be one of those folks that have a bad reaction to the actual virus. So that's why we highly suggest getting the vaccine if you are in that group. And along to go with Dr. Dixon, be skeptical, read the pamphlet, ask the questions. We want you to do that. We like informed patients. They're the ones who tend to do better.
We've got a question here. How long will the vaccine protect me? And what if I've already had COVID? Should I take the vaccine?
That is such a great question, some of which we don't know the answer to yet. So in terms of how long the COVID vaccine will last, the answer is we don't know. It's the same question as if you got COVID, how long will your immunity last? And the answer to that is also we don't know. So that's data that's currently being worked on, and I'm sure that as we have more information on that, that will be presented. But as of right now, it's unclear. In terms of whether or not you should get the vaccine if you have had COVID, the CDC is saying that if you got monoclonal antibodies or if you got the convalescent plasma, it's probably best to wait 90 days before you get the COVID vaccine. And they don't say that because you necessarily shouldn't get the vaccine within that time frame. The thought process is that because there is some shortage of the vaccines in certain parts, that waiting in 90 days after, you're more likely to have the antibody already and have an immunological protection based on having received the antibody. So waiting that 90-day period before getting the vaccine is reasonable. Metro Health, for example, is recommending waiting 90 days if you've had COVID regardless, because they also suspect that your body would have developed antibodies. Having said that, we have seen people who have developed COVID and come back with reinfection of COVID. So I think that this is where you're sort of weighing your risk benefits, and there is no recommendation. And I think without speaking for anybody, the recommendation is that having COVID, we would still recommend that you get the vaccine. Being that at that point, by getting the vaccine, you know that your body is developing any protection for COVID. So I think that if you have had COVID, you can still get the vaccine. And if you, for example, and I don't think this is part of the question, but I'll add it as a piggyback. If you got the first vaccine, got COVID, that does not preclude you from getting your second shot. So you should still be getting your second shot of COVID. And I think earlier someone asked about if they had never had the flu shot, and we had such great answers to that. I wanted to piggyback on that and say that if you've never had a flu shot, by getting COVID vaccine does not by itself mean that you're going to have a harsher reaction. And like Dr. Robinson very clearly said, everybody's reaction is going to be different, but that's not necessarily because you never got a flu shot.
Yeah, so just to sum up, if you've had COVID, you should still get vaccinated. It's not going to make the vaccine worse or cause problems. If you're not sure if you've had COVID, you should still get vaccinated. One of my cousins is a neonatal ICU nurse, and she got COVID from a preemie baby who was born with it from a mother, and they tested her for antibodies before giving her the vaccine. And even though she'd had COVID and had symptoms for a week, she didn't have any antibodies, so they vaccinated her. So just let's protect each other.
It's better to be safe than sorry. And, I would rather have my seatbelt on in an accident with the possibility of being saved than not have it on it and the possibility of not being saved. Did that make sense?
That's a great analogy. I say there are risks to wearing seatbelts.
Yes.
And some people have died because they had their belts, but we still do it because the chance of dying from not wearing it is higher.
Right. And like on the airplane, it says, put your mask on before you try to assist somebody else. So this is us putting our mask on. Well, the time is drawing now. We've been talking now for a good hour. And my good people will tell you that I am one that is conscious of time unless the Spirit takes control. And the Spirit has left us tonight.
There's one more question. Can we answer this one question before we go?
Yeah, I didn't see it. Thank you, Jakithia.
Absolutely.
One more question. Have you seen anyone with severe reactions to the vaccine in the OSU emergency department? Did y'all hear me?
I can probably answer that. Sorry, I've been quiet listening. Very engaged.
Yes.
I did have a patient 2 days ago who came in, got her first shot. 11 hours later, came in with facial swelling. She had eye swelling, felt like she was having a lot of nausea, felt like she was going to pass out, took Benadryl and came to the ED. And she had few symptoms that were concerning what we call anaphylactic reaction. Because she had some difficulty breathing and things like that too. I do want to preface that by saying these are expected or can happen with any vaccine, including the flu vaccine, including any other medications as well. But after she took Benadryl, she was a little bit better. We had to give her epinephrine as well. We had to give her some steroids to prevent additional, like what we call delayed reaction. And when she actually came, she came with a paper that has a hotline for the vaccine, to call a hotline to report your reactions to see what the next steps are. So resources are still included. If you do have these kind of symptoms, do come to the ED. Those could be life-threatening, and get it checked out. And based on what kind of symptoms he had, besides just the malaise, fatigue, and things like that, those are expected. But if you have difficulty breathing, if you feel like you're gonna pass out, facial swelling, tongue swelling, and things like that, immediately go to the ED. And the instruction from that is called severe reaction, and you should not be getting the vaccine. Let me repeat that again. This is not the only, COVID is not, this is not the only vaccine that could potentially give you anaphylaxis reaction.
Yeah, I was going to add to that, doctor. I was 20 some years old when I found out I was allergic to codeine. Had never had any problems, was in the hospital, and all of a sudden I had a reaction to codeine. My mother had been taking this blood pressure pill for years, and her body developed an immunity to it, and she reacted to it. So we reiterate, any shot, anything that's foreign to the body, the chances of having a reaction is possible. So we need to make sure of that.
Yeah, and it's not a big chance. And
Yeah.
it's
Yeah.
6 in a million.
Yeah,
Yes.
and then I think the other one is 2 out of like a million or something.
Yeah,
like that.
according to Dr. Fauci.
Yes.
Mhm. And the other thing is, when people get the COVID vaccine or any vaccine, there's that vaccine information statement that is put out. And so ask for that. It should be offered to people and read it over. And it gives you all the information and what the reactions can be, just again, to try to make yourself more informed about it.
Okay. Doctors and host, how have we done tonight?
Yes, sir.
Good.
This was so much fun. Thank you so much for putting this on, especially thanks to Keithia, who had this idea and pushed to get this going, and to Pastor Davis and Pastor Shepherd for letting us come talk.
And thank you so much. We have another Mercy on the line, Reverend Shepherd's granddaughter. Reverend Shepherd, let Mercy be seen so she can meet Mercy Dickerson.
Hi, Mercy. Hi.
Miss Mercy too.
Easy.
Yeah, I'm Mercy. It's nice to meet you.
Very nice to meet you.
You all have a good night. We've enjoyed you, and we want to thank you for your time tonight and for you being frontline workers. We do appreciate you, and our prayers are continually with you for your safety as you look to the health care of others. You are, if you drive past 461 St. Clair Avenue, there's a sign that's saying thank you, and we want you to know how much we appreciate you and believe in you.
Yes. Thank you all so much.
Thank you for having us.
Thank you so much. Thank you for having us.
Thank you.
Thank you for having us.
And I learned a lot too.
Yeah.
We all learned a
Thank
lot.
you.
Yes.